We'll discuss the OT setups and ergonomics in laparoscopy surgery. Okay, so basically the OT setup. First thing you have to know the basic setup, that is the laparoscopic tower self. Okay, in you can see this is the laparoscopy tower cells. This contains imaging systems. This is the imaging system. This is the insufflator. This is the electrocut units. So basically the you have to remember the surgeon scan, if you it is should be in front of your surgeons, so that can rapidly, that if it is in front, then easily you access the any equipment problem, that loss of insufflation pressure for rapid troubleshooting. Electrocutter unit should ideally, very important, this should be separately placed, because there will be a electromagnetic field, so that will cause to avoid antenna coupling. So the chances of coupling electrical current can be transferred for one to through the electromagnetic field. So to avoid, you have to keep separately. So this is the light source, the fiber optic cables powered by high intensity light source such as xenon or halogens. So basically xenon is the best illuminations by a powerful source. Minimum, it will cause minimum heat generations. So it will cause cold light. It will not cause very hot to the patients. So that will cause decreased burning part. The light is usually absorbed by UV blood, that will cause reduced visibility. So you have to clean the before clean the lights also during the procedures. Output from the light source is conducted to the telescopes by a fiber optic cable. This is your light source. This is the fiber optic cables. The output is coming through the, this is the output connections, the coming to the light out source is conducted to the light telescope by light cables containing this light cable, either a glass fiber bundles or a special fluids. Okay, then the light cables, this is a fiber optic cables that will transmit light through a very fine flexible glass or plastic fibers. The fiber size is 20 to 150 micron in diameters, and a good optic fibers cable will transmit all the spectrum of light without any loss. The fiber optic cables is able to transmit enough heat to burn through the paper drifts or cause skin burn. So very important, you should take cautions during when manipulating the light cables. The liquid crystal gel cable made of clear optical fiber capable of transmitting up to 30% of more light than optic fiber. So liquid crystal is more chances, more light transmission compared to your optic fibers. Then the your scope laparoscopy, there will be two types. The one is rigid, one is flexible. You can see any other procedure like flexible endoscopy in the endoscopy, upper J endoscopy, nasal endoscopy. The rigid is usually used in our setup like gynec surgery, urology, any other general surgery. You are using this rigid telescope or laparoscope. The standard laparoscope consists of metal shaft. This is the metal shaft, 24 to 33 centimeters in length. Structural difference is the number of the rod lengths, that is 60 to 18 rod length systems. The angles between angle of view, you have to see the angle of view change to 0 degree to 120 degrees. This is the fiber optic light source. This is the fiber optic cords. This is the ocular lens assembly. This is the eyepiece that is connected to their camera ports, camera head. This is the lens strength, the objective lens, digital orbital, light fiber and shafts. The diameter of the lens is 1.8 to 12 mm. So very important. The angle of view with telescopes, there will be two, one is 0 degree, one is 30-degree forward oblique angles. The 0 degree does not alter the angle of visions, but it has a better panoramic view sufficient for diagnostic procedure. Is 0 degree is very easy for if you use 30 degree. 30 degree has the advantage that it is underlying area difficulty, anatomical and conditions like those area you are not able to see properly in a 0 degree, that is the radiations, the undersurface of ovarian surface while sealing uterine vessels and while doing a pelvic lymph dissections. So these are the lights, this is the light source input, this is the camera inputs, this is the scope. This is 0 degree, 30 degree or 45 degree. Okay, then next unit is your diameter of telescope. There will be 10 mm, 5 mm or less than 5 mm. Most commonly you are using for both operative and diagnostic purposes is 10 mm port. Then next is mainly used for diagnostic purposes, can be used for operative sometimes, and very delicate mini laparoscopy, that is less than 5 mm diameter of telescope is used in children, that is 1.1 mm is the minimum. The lens system, there will be two, one is conventional thin lens system and is Hopkins rod lens system, that is most commonly is used is Hopkins rod lens systems. So there is a camera we need. The first medical camera was introduced Kirkon Corporations in 1972. Camera, there will be a camera head, there will be a cable, there will be a cables, and that control is connected to the trolley along with the monitors. The camera head is attached to the laparoscope, that is the eyepiece, and this is the, then the monitor basic principle is of image is horizontal beam scanning on the face of the picture tube. The placement of monitors should be 10 to 20 degree below the surgeon's eye level, so that it will cause not cause any movements of the neck, that will cause extension of the neck, that is cause of pain to the neck pain or back kicks, neck pains. Okay, then this is the insufflation system that is designed to deliver your gas. That this is the distension of the abdominal cavity. The optimal visualization of pelvic organs basically depend on the how much distension the pelvic organs. This is a very needle harassment tracker is used during insufflation. The flow, this is the pressure, set pressure, this is the flow rate, this is the total volume of gas you come going inside into abdominal cavity. So basically this shows intra-abdominal pressure, this is the flow rate, this is the total volume of CO2 consumed, and initially the flow rate should be 1 liter per minute, then it's gradually increased to 2.5 to 3.5 liter per minutes. During insufflation, the intra-abdominal pressure should not be exceed, very very important. The preset pressure has to be minimum 15 if it is a very obese patients or very thin patients. Then you go for a 20 mmHg. The rapid insufflation causes dysarrhythmia and post-operative pain. CO2 most commonly used. Why this is used? Because the advantage is a high diffusion coefficients, rapidly clear from the body. Sometimes it is very highly soluble in blood and tissue, so it does not support any combustions. It is, and it sometimes it convert to carbonic acid on most moist with H2O. CO2 is converted to carbonic acid, that will cause peritoneal irritation, cause pain.